with Dr. Shenoy, and he's going to be talking about DOACs for VTE, how to keep patients out of the hospital.
Hi everyone, I'm Sandeep, and I'll be talking to you about the outpatient management of DVT and PE with a focus on DOACs. Okay, I have no disclosures, and in the next 5 minutes, what I'll be trying to talk about is what the guidelines have to say about the outpatient management of DVT and PE. What tools do we have to stratify patients as to who can be treated in the outpatient settings, and an algorithm in terms of follow-up for all our patients whom we are managing in the outpatient setup. So the CHEST guidelines essentially say yes, patients can be treated in an outpatient settings provided they're hemodynamically stable, there are no contraindications to anticoagulation, and there's a reasonable sense of understanding from the patient's perspective on the disease process and in terms of compliance and follow-up. The ESC guidelines in 2014 essentially classified pulmonary embolism into high, intermediate, and low risk based on the presence of hemodynamic stability, the PESI score, and the presence of RV dysfunction and cardiac biomarkers. The cohort that would be of interest to us would be the low risk group. Doesn't mean everybody in the low risk group can be treated in an outpatient settings, but the art is in trying to pick the right patient in this group. Obviously, as mentioned before, all the findings that would suggest an intermediate or a high risk PE would automatically be disqualification for outpatient management. The ESA guidelines do talk about the PESI score, the simplified PESI, and the Hysteria criteria, but they don't specifically say which one is the preferred one. Now, as you can see, the PESI is a complicated tool which you can use, and eventually at the end you'll find you can classify your patients into class 1, 2, 3, or 5 to 5. The group that would be of interest here would be the class 1 and class 2, where you can see that the mortality is less than 3.5% in both the class 1 and the class 2. Something that's simpler to use would be the simplified PESI. It's simple to use, it's validated, has high negative predictive value and sensitivity in picking out the low-risk PE. And at the end, all you get is a low risk or a high risk. And as you can see, the high-risk PE automatically has a mortality of 10.9% compared to the low risk, which is 1. The Hysteria criteria is a group of questions. If the answer to any of which is yes, automatically disqualifies patient from being treated as in the outpatient settings. There are a few differences between your PESI score and the Hysteria criteria. For example, history of cancer and chronic cardiopulmonary diseases are excluded in the Hysteria criteria, which are markers of high mortality in the 30-day period. Whereas it does include other features like the need for thrombolysis, contraindications to anticoagulation, and a few patient factors as mentioned there in terms of trying to decide who can be treated in an outpatient settings. Now, when we have all these guidelines and the criteria, one effective way of putting all of them together is, especially when you have a patient at the bedside or in the clinic, is go to the SVM website, click on the practice tools. It'll take you to this mypulmonaryembolism.com webpage, which is essentially a tools which is designed by the SPM. You plug in the patient characteristics, and at the end, it'll tell you if your patient can effectively be treated in an outpatient settings or not. Simple. Now, in terms of lower extremity DVT, the two main points that I want to stress about is iliofemoral DVT and the presence of phlegmasia are automatic disqualifications from outpatient management, whereas the rest of the ones that you decide to eventually treat in an outpatient settings, send a test script to the pharmacy who can then determine what would be the most cost-effective option for your patient. Just to remember that when you're sending a test script, also send for low molecular weight heparin, because if you're doing dabigatran or edoxaban, these patients would need at least 5 to 10 days of bridging before they can be transitioned over. So once you have this, have a good, robust follow-up plan for these patients. Now, in terms of anticoagulation prescriptions, your one-drug therapy with apixaban or rivaroxaban is preferred. It's easy to remember, and especially can be done in most of your non-cancer VTE patients. In your cancer VTE patients, especially the non-GI malignancies, edoxaban is an option, especially from the Hokusai VTE trials that was recently published. We do have some data on apixaban and rivaroxaban, but nothing concrete as of yet compared to edoxaban. In terms of follow-up, anybody from your clinic can call the patient on day 1 to ensure that he has picked up the prescription. Day 5, 7, and 21 would be ideal days to call and follow up on these patients to ensure that they have transitioned well from low molecular weight heparin to edoxaban or dabigatran on day 5 and day 7 and 21 for the other two DOACs. Have a follow-up appointment at 3 months to see if it was a provoked or an unprovoked event to decide what would be the duration of therapy. 6 months follow-up would be warranted for all these patients with unprovoked VTE to decide if they can be transitioned over to the lower dose apixaban 2.5 or rivaroxaban 10 milligrams daily. At every clinic visit, ensure adherence, compliance, bleeding complications, progression of the disease, new medications which have been added, and access to barriers to treatments. In conclusion, these are the factors that you cannot consider outpatient therapy, and as you can see, the big ones in this are a high PESI score, presence of right ventricular strain on imaging, and socioeconomic barriers, or other reasons the patient needs to be hospitalized. Thank you.